Firstly, I would like to wish you all a happy Mid-Autumn Festival first. This is a Chinese festival in the past 3 days, so today is the last day. It's actually similar to Thanksgiving, so everyone is getting a reunion even in the family. I have no commercial affiliation to disclose. So today my talk will have a brief view on the overall view of the Madelung deformity and the spectrum, and also my preferred treatment. So I think most of you know the Madelung deformity is associated with low real dyschondrosterosis, and it's because of SOX gene deficiency. And most often we will find that ligaments associated with this deformity. And deformity is actually a ulnar radial physis growth defect. And we may see the lunate subsidence and also a V-shaped carpus. And many of time is bilateral. But actually, this Madelung deformity is a spectrum of disease. And Dr. Ali from the Dance group have identified some of the different disease spectrum. Most common is only the distal radius is affected, and some of the patient may have the entire radius is short. And also there are very rare case of a reverse Madelung deformity. So these are some of the example. The distal radius type, that means that only the distal part of the radius is affected. But some patient may have an entire short radius. And or sometimes they may have a reverse Madelung deformity. That means the deformity is deviated to the dorsal side. So the weakest ligament is thought to be one of the culprit, but actually we do not know whether this is the cause of the disease of the result of the growth arrest. So it is a ligament that's from the volar and ulnar side of the distal radius going mostly to the lunate, but some of the fibers may attach to the tricipitrum. So actually the natural history of this Madelung deformity is not very well known. Sometimes, occasionally, we may see some patients in their late adulthood and presented with no symptom at all and incidental finding of a Madelung deformity. Of course, there are some literature of extensor rupture caused by the deformity, but actually how common and how often actually we do not know the real natural history. So what will I do if I encounter some pediatric patients? Well, if I meet a pediatric patient in the early stage, that means before 11, before there's still a lot of potential growth. Of course, I will refer to the pediatrician and also perform some genetic study. And I will firstly monitor the campaign and also have a careful assessment. And I will only consider a ligament, weakest ligament excision and interposition of the disease physis only if the patient is symptomatic. But if the patient is presented late, of course, I will also treat the patient only if they have symptom. That means I will monitor the symptom, and if the symptom is severe, I will may advise for a reverse wedge osteotomy. So actually, from the literature, there's some authors advice for the weakest ligament excision and also fasciolitis and interposition. But the result actually, I'm not quite sure because from the literature, I found some mixed result. So I must admit that if I decide that it should be a shared decision with the parents and explain to them what is the current literature state. However, there's some recent paper that also advise for some guided growth with the radial side. That means to put in a small guided growth plate in order to slow down the radial side growth of the distal radius. But this is not the topic for today. I just want to share my technique on the reverse wedge osteotomy. There's a few papers talking on this technique. The first one I found was from Madelung and reporting the cases in 2013. And then another Japanese doctor reported a case report in 2021. So the technique is to perform a reverse wedge osteotomy. That means taking on the both anterolateral wheel and also anteroposterior wheel and also the lateral wheel. Both sides is a wedge, and then reverse the wedge to correct the deformity. So this is what this is the photos from the Japanese paper. So one case example, this is a 14-year-old girl, have a Madelung deformity, and she is quite symptomatic of pain on the radial side. Sorry, on the outer side of the wrist whenever she moves the wrist. So the MRI showed the presence of the weakest ligament, but she's too old for just excision and also excision of this ligament and also physiolysis. So the technique of about the osteotomy should be performed about 2 centimeters proximal to the physis, and after protection of the Hoffman, and the initial volar cortex will be opened up by a saw. And then I will use 2 parallel osteotomes, one on the radial side and one on the outer side, and gently with small advancement on each side. So one side, when you taper in, it will get stuck, and then you start to taper on the other side, the radial side, because the bone open up the radial side, osteotome will be loosened, and at that time, you know, there's some more opening up of the osteotomy, and then advance both sides slowly, so to avoid any extensor tendon injury. So the size of the wedge, how to determine, because the wedge have to be in both plane, and usually I would decide to correct the deformity. Say if the difference of the height, the radial height is 10 millimeter. If I will aim for the final radial height is millimeter, then the difference is 7. So I will take half of this, because once we reverse the wedge, if it's just a closing wedge, once we take out the wedge, it will close down for a 4. Say if I take the wedge is 4 millimeter. If I just remove the wedge and take a closing wedge, the decrease is 4 millimeter. But I put back the bone graft and then check up the outer side for 4 millimeter. Then the overall correct will be 4 times 4 will be about 8 millimeter. But why I will take a little bit more, I will explain on a little bit later. So the fixation, we have to use a locking plate. And we cannot use the anatomical plate because we have to, actually we use the anatomical plate, but we have to bend it into a straight plate. Otherwise, once we correct the volar slanting, the ordinary anatomical plate will not accommodate the deformity. So we have to bend the plate to a straight plate. So this is one of example where we protect the soft tissue, cut out a wedge, and then reverse it, and then perform the fixation. So you can see the on comparison the before and after of the fixation with this volar reverse page reverse osteotomy. So in summary, this should be performed for the child approaching a mature physis. That means in early age, I would advise to not use this osteotomy. It's relatively simple in design and operate, and of course, the correction power is also very good, and there's no special instrument needed, and it's also a stable fixation, and the child can immediately mobilize. But one of the problem is it still have some learning curve, because sometimes it tends to have undercorrection, just like this case I've performed. Even after the wedge ostomy, the opposite side is not closed enough. That means I have some tendency to undercorrect the deformity. So there's still some early case that you may have to check frequently the intraoperative X-ray to see if the correction is good. So these are the reference. So this is the end of my talk.
Okay.
Yeah.
Good morning, good afternoon, good evening, everybody. It's an honor to me for me to be here. Thanks, my friend Francesco, for the invitation, and thanks, Chan, for the excellent lecture. You showed us many good cases and a very good experience in Madelung deformities, and we have many questions. We have many questions. Chesco sent us many questions, and I will begin with. There are many questions about the release of the phases. When do you perform the release of the phases? When, and what your results with this technique?
Well, actually, I must admit that I do not meet a lot of young child with Madelung, because firstly, my hospital is not a pediatric hospital. I'm working in a general hospital, and it's very difficult to pick up those child very young. So but from my experience and from the literature, before 11 years old is the limit. So after 11 years old, you probably cannot have any good result.
Okay, Campbell Wang from Melbourne has a question. Whole bone form of Madelung is in association with radial head instability. Any strategies in this case?
Well, I do not have a lot of cases of the whole radius is short, but I think in most of the Madelung with Luriville chondrosteosis, they do have some short. The whole radius is a little bit short, but of course not to the extent of those I shown in the talk. So many of them have some radial shortening but it's not a severe type. So I do not see a lot with instability of the radial head. So how about I don't know. How about you, Antonio? Do you see a lot of radial head instability?
Okay, and I think everybody has this doubt, this question. What happens with the distal radius ulnar joint when because you have a deformation in the sigmoid notch, and when you perform osteotomy and you correct acutely this joint, what happens? And what happens with the pronation and the supination?
We do not investigate the orientation of the distal radial joint alone, because we just monitor the symptom of the patient, and actually my patient do have some improvement in the ulnar side wrist pain. So I cannot tell what exactly, but because they are approaching skeletal maturity, the remodeling power may not have a significant remodeling power, but most of them, they do have improvement in the symptom.
Okay, another question. Do you have experience in 3D reconstruction, like a model with a plastic model?
Sorry, may I beg your pardon?
Yes. Do you have experience in 3D model in a plastic model.
Yeah, okay.
Yeah, in
3D printing. 3D printing.
Yeah.
Well, we are just developed the 3D printing in past 2 or 3 years. So we'll, if we find suitable case, we'll use the 3D printing model, but not in the past 2 years. Yes. So probably we will develop that. Yeah.
I have a few experience with a regular plate, radius plate in Madelung, because I believe this radio is too small and too deformed, and especially after the osteotomy, and you have a deformed radius, and after osteotomy you have a more deformed radius. Or how do you accommodate the plate in the anterior surface of the radius to avoid friction with the tendon?
We just cover it up with the pronator muscle. So because we put in the volar side, so we cover up with the pronator muscle where I think it should be fine. But what I have explained, we have to bend the plate to become a strict plate, because most of the dislocated plate do not cannot accommodate the deformity. So what was your experience? Do you have to bend the plate also?
Okay, and my last question.
I'm
sorry. I'm sorry.
It's okay.
My last question is, what are you using to perform the unit shortening, and when, or never?
You mean the ulnar shortening?
Yeah.
I think in most of the situation, in most of the situation, I do not need to perform the ulnar shortening at the first stage. So I will not do the both radial corrective osteotomy and also the ulnar at one operation. Only if the patient later may develop ulnar side problem, I will then perform a second operation to perform the ulnar shortening. So I will not aim at one operation to correct the radius and also shortening ulnar.
Okay, Sean, thanks a lot, and congratulations for your lecture.
Yeah,
Francesco, Francesco, please.
Caco, in your institution, you did a study, maybe for different patients, maybe for very late, so patients in a very late stage. You compare, I think, Soveka-Panji or radial ulnar hernia section with reconstruction. Can you talk about that?
Yeah, we have some case with, because we believe the distal radius joint is very difficult to have a good joint after this osteotomy, because the radius is deformed, and after the osteotomy is more deformed. Then we have some case with osteotomy, radius osteotomy, and Soveka-Panji procedure, and we don't have problem with the distal, with the Soveka-Panji. I think it's a good procedure, and you can reduce the distance between the distal unit and distal radius, and we have good results without problem with the impact with the proximal stump with the radius. We don't have problem. I think it's a good technique.